And I think this is a very, very interesting topic on the menstrual cycle and its clinical implications. We are ready to learn. And thank you again for joining us. Just to remind everyone that this is the Clinical Care Platform's mission, which is to improve patient care. And I strongly believe that this program that we are going to host today will significantly contribute towards helping you to stay updated, but importantly, to maintain your competence. Menstrual cycle, I'm really, really looking forward to this one. Just to say that all our events are open access. As a health worker, you may attend as needed. However, I want to encourage you to become an official member of the platform so that you can enjoy CPDs and many administrative support services like reporting your CPDs to the council, etc., etc. And yes, yes, we have issued over 60,000 credentials to various health workers. If you are not part of the 60,000 credentials, please do join us so that you can have a peace of mind. And the way to do it is to just visit our website right there. As a platform, we do over 144 live webinars per year. Our members enjoy a library of over 100 CPD accredited courses. And also we have master classes. Oh, by the way, we had a very, 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 I don't know, should I say wonderful? I don't know the right word, but it was a beautiful, wonderful, empowering master class in obstetric emergencies. And I'm hoping, Dr. Billy, we can bring it back very soon. And yes, the diplomas are open for registration. So please get ready to join us because the coaching sessions are starting next week. For October the 19th, we have the palpation fine needle aspiration boot camp limited to 20 seats. So please, if you are joining us, register as soon as possible. And yes, the diplomas are back. Many people have written, many people have passed. If you are planning to write your exam in 2025 February, please join us. If you're not planning to write, but you would love to improve your clinical competency and skills, join us as well. Everyone is really welcome to join us. Like I said, in terms of the master classes for October, there are two. It is the palpation fine needle aspiration bootcamp. This is in person. You must be willing to come to Joburg. Then we have the point of care ultrasound. We really want you to sort of replace your stethoscope with an ultrasound. It's the modern era of things. And yes, yeah. So let me not waste a lot of time and officially hand over to Dr. Magagula to introduce today's topic. Why are we talking about the menstrual cycle? And also to introduce our speaker. David, welcome. I think Billy will also introduce you. Thank you.
Thanks, Alex. Thanks for that warm welcome. It's always good, to meet at this time on Mondays once a month. So yeah, it's really, really awesome. We all know David. He needs very little introduction. Thank you so much, Dave, for joining, brother. We appreciate your presence and your awesome contributions as always. Shadow is my sister. She's there in Gauteng, in Joburg, very close to you there, LS. She's an obstetrician and gynecologist,
Good.
an advocate for women's health and reproductive freedom. She did her undergrad as well as postgrad studies at VETS, as well as her specialization through the FCOG, through the CMSA, her FCOG qualification. She has worked in multiple state hospitals in multiple provinces in the country, but she loves Bara. She's got so much energy. She's a hard worker, and the favorite of all of them is Bara. So
Ooh, wow.
that shadow.
That country.
Exactly. Yeah, so that's awesome, man. Yeah, so she's currently in the East Rand, in the East, is it, yeah, the East Rand, right?
Yes.
Hey, East, yeah,
Yes.
yeah, she's at Netcare N17. Yeah, those people, they are very lucky to have her as one of their obstetricians in the area there. She believes in the education of women about their bodies and empowering them through understanding and appreciating their bodies. Somehow, I was just thinking, Alice, that perhaps, this webinar should have been open to the general public so that they can learn what the menstrual cycle and what it is, and what it represents. And it's really the foundation of what we do in Ops and Gynae. So I think this is probably one of those we should have early on in the year, to build a foundation for the rest of the year. So yeah, thank you for that, Shadow. I appreciate your work, your effort. It's not easy to prepare a talk, colleagues. Yeah, it's not easy. So if anyone is willing to come here and give us a talk, we must know and appreciate the effort that has gone into it. So yeah, thank you so much for being ready for us. Almost 500 of us are ready to listen to you speak. So yeah, go ahead.
Thank you so much.
You forgot to welcome David. Welcome, David.
Yes, I'm here. I'm here. I'm
I get it
present.
again.
He did actually acknowledge
Thank
my
you, colleague.
presence.
It's those glasses, Dave. Don't worry. Those glasses he keeps wearing.
Sure.
Okay. Thanks, Doc. You may share your screen. Yay.
All right. I can start?
Yes, Doc, you can start. Colleagues, let's welcome our Dr. Msibi with lots of hearts and hugs and applause. Thank you, Doc. You may start.
Thank you, everybody. As I've been introduced, I'm Dr. Nomshado Afolayan. And thank you so much, Dr. Billy, Dr. Lesego, Dr. David, for allowing me to come into your platform and do one of my favorite things, which is to teach and to share the information that we were so graciously taught a couple of years ago. Thank you. I'll be presenting on the menstrual cycle and its clinical applications. I think the menstrual cycle is such an important thing to focus on because it literally governs most of, if not all of the work we do as obstetricians and gynecologists. And it also plays a huge part in all the women's lives, whether it's starting, it's finishing, it's going wrong, it's going well. It literally does take over most of our lives. So what to expect in my talk? I'm gonna do a menstrual cycle definition. We're gonna look at the hypothalamic ovarian axis, but I like to add an E because the endometrium is very much a big part of the system. So I call it my hypo-E axis. Then we'll do some clinical applications, and then we'll do, I think something we don't talk about enough, benefits of having an actual period. And then we'll look at future topics, which I saw one of my favorite topics is already coming up very soon, which is PCOS. Okay, so in terms of your menstrual cycle, it's a series of natural changes in hormone production with ovarian and uterine structural changes to produce an ovum to facilitate pregnancy. Basically, your period is there to give you a baby. If you don't have a period, then you're not gonna have a baby. It has 4 phases, which we'll look into a little bit more deeply. And each cycle has an average of about 28 days, going from about 21 to 35. And your period literally goes from menarche until menopause. It starts around 12 years old and ends around 51 years old. And obviously in medicine, it doesn't have to be at 12. It can be anywhere between 9 and 16 years of age. It doesn't have to end at 51 years old. It can end anywhere from 45 years old to 55 years old. Everybody's different, and we just wait upon each colleague. Sorry, yes, just wanted to take something down. Sorry. All right. And then in terms of the phases, you've got your first phase. Every period starts day 1 on the day of menstruation. So this is shedding of the endometrium, and it usually lasts about 1 to 5 days. You've got a follicular phase, which is the regular cyclical growth and maturation of follicles. This overlaps also with your menstruation, and that lasts 1 to 13 days. And then you've got the beauty and the grace of a period, which is ovulation, which is the release of a mature ovum in order to facilitate a pregnancy. And that happens around day 14 in a 28-day cycle. And then we've got our luteal phase, where you form a corpus luteum and you've got further endometrial proliferation. This is about 15 to 28 days. It's also important to note when the cycle sizes increases and decreases, the part that mostly changes is your menstruation and your follicular phase. ovulation is always more or less in the middle of your cycle, and your luteal phase is almost always 14 days as it follows as such. So the first thing we'll be looking at is your HPOE axis. So the first thing you'll see, if you note there, you've got your hypothalamus, which is found inside your brain, which releases gonadotropin-releasing hormone in a pulsatile manner. So from the age of menarche, so from your first period, the hypothalamus is triggered in order to start releasing gonadotropin-releasing hormone. This hormone then moves down the brain into your pituitary gland, and it affects the anterior part of your pituitary gland to produce follicular stimulating hormone and luteinizing hormone. These hormones then go to your ovary, where they stimulate the theca and the granulosa cells of your ovaries to produce estrogen. Then when this estrogen is produced, it first gives us a negative feedback to your gonadotropin-releasing hormone and to your FSH in order to stop the process of stimulating more follicles to grow. The estrogen also promotes endometrial proliferation, and it also promotes the LH surge, which will give us the ovulation. And once you've released an ovum, you then go into your luteal phase, which then, if there's no impregnation, then you are then going to have a period. The first thing we are going to look at is your menstrual phase, which usually lasts from day 1 to day 5. For some women, their period can be anything between 3 to 8 days. So it doesn't have to be 5 days. This is shedding of your lining, where you release the stroma of the endometrium, glandular tissue, leukocytes, and blood into your vagina, therefore out into a pad or tampon or whatever the patient is using at that time. There is a strict play between coagulation and fibrinolysis, which controls the bleeding and the stopping of the bleeding. So if there is not enough fibrinolysis, you get a lot of clots because then which usually happens when you produce quite a lot of blood. So your menstruation phase is actually triggered by the drop in progesterone and estrogen. So the things to watch out for, because I thought this must be a little bit more of a clinical-based topic, so that we're able to know what to look out for and what to do. So you need to watch out for things like heavy bleeding. So heavy bleeding is actually quite a difficult thing to diagnose. Most patients will have a heavy period and they won't know it's heavy. Most women think it is normal because most women would have had it for most of their life, or a gradual increase of the period. Therefore, they don't identify it as abnormal. So you need to ask patients the number of pads they are using. Number of pads, 3 to 4 pads a day is fair. 3 during the day and 1 to change at night. Anything more than that, you need to start questioning your patient a little bit further. Some patients change their pads more frequently just because they don't like the sight of blood. So you need to make sure your patient's not changing because they don't like blood. They're actually changing because their pad is actually full, or they start leaking if they don't change within a certain period of time. So this makes your history taking during consultation extremely important. The other thing that women do once they have heavy bleeding is doubling, where you use a tampon and you use a pad. So that is some of the things you need to also look out for. You also need to find out the size of the pad women are using. So if somebody is saying, I'm using the pads that women use after they've delivered babies, you need to worry. That's a very thick pad. That's a pad that holds a lot of blood inside of it. Patients who say they are leaking, so if I sit for long in a class and then I start leaking, you need to worry. That's heavy bleeding. Clots are actually an abnormality. So when blood leaks into your vagina, it spends a little bit of time there. So there is a chance of it clotting, but it shouldn't be big clots. Small clots that appear because you were sitting for long, because you wore a tampon, those are understandable. But once we have big clots, or clots that patients will even describe the sound, that it was like, boop, something fell into me, then I knew I was bleeding heavily. Those are the things you need to look out for. Then obviously signs and symptoms of anemia, question your patients around that, dizziness, easily fatigue during their period, looking pale, unable to carry out normal duties at home. Those are the things we need to worry about. You also need to worry about patients who are having a light period. It's not normal to wear one pad the whole day throughout your period. That's not normal. That's too light. You need to also ask about things like spotting. I've seen quite a, I think private is a whole different jungle. You're exposed to more pathology, more specific pathology, unlike the fast pace of Bara where we're pushing queues. We sit with patients for longer. And you find some patients are literally spotting, having a period for 1 or 2 days, and they're not sure if this is normal or not. Therefore, it's upon us to ask the right questions and be able to unpack pathology within our patients. Watch out for things like pain also. So if patients are having severe pain during their period, that's something we need to worry about. If patients are needing analgesia for periods, that's something to worry about, because a little bit of cramps, a little bit of discomfort is palatable. But once you start needing analgesia and you can't go to school and you can't perform your daily duties, we need to worry. Another thing we need to also ask around the menstrual period is PMSing. How bad are you PMSing? I'm going to go into detail on all of these later on, so I won't dwell too much now. This is the heart of the menstrual cycle, literally the follicular phase within that ovarian cycle. So the whole point here is to produce a mature ovum. If you look on the top right-hand corner, you'll see the gradual growth of a follicle. So it literally starts with the part of it that is gonadotropin independent, meaning it's happening whether you are releasing FSH or LH or not. It's part of the ovary's normal functioning. And this has the follicle going from primordial follicle, it's recruited into a pre-antral development. And this is void of gonadotropins. And it takes around 120 days. It happens from the time you are born until the time we start introducing gonadotropins to further stimulate the growth of these follicles. So we go from a pre-antral follicle into an antral follicle. So each woman will release a large number of follicles per month. Only 15 to 20 of these pre-antral follicles will become antral follicles, more mature follicles, which are known as Graafian follicles. This happens in response to the stimulation from your follicular stimulating hormone and your LH hormone. This also uses a two-cell, two-gonadotropin theory, where the two cells are your thicker cells from the follicle itself. If you look at the top picture, you'll see there's a black dotted line. Those are your thicker cells. Then there's the yellow pack of cells, which we then call your granulosa cells. The inside, you have an ovum, which is the egg that must mature throughout this process. So your thicker cells, which is your outer part, which is vascular, will absorb LDL from your body and then convert this LDL into androgens in response to the hormones. Then it takes these androgens and puts them into the avascular granulosa cell structure, which will then produce estrogen by aromatization of these androgens. This also leads to further development and filling of fluid within the granulosa cells. As you can see, it's structurally changing as it goes into a larger antral follicle. Inside this fluid, there's hormones, there's proteoglycans, and there's plasma transudate, which help to grow the ovum and to keep it healthy and continue the further maturation of this follicle. The granulosa cells then become luteinized and produce progesterone to push a pre-ovulatory phase of the follicle. Then your pre-ovulatory follicle, once it has grown and it becomes fluid-filled with the mature ovum and more luteinized, then it inhibits the FSH and produces inhibin. This then causes atresia of the other 15 follicles that were growing around it, which then makes this pre-ovulatory follicle the queen of this pack that is going out to try and give us a baby. So now that this follicle has grown above all the other follicles, it's then able to steal all the estrogen around it as it is larger and has more FSH receptors that are able to continue the maturation of the follicle and the maturation of the ovum inside. The thing to watch out for here is things like PCOS and hirsutism, where you have a high androgen level. And the problem with high androgen is that it promotes poor follicular growth and more atresia than necessary. And then it also causes anovulation and infertility. The minute you have anovulation, you then have longer periods with more thickened endometriums, which predisposes you to heavy menstrual bleeding the day you eventually have a period. Then infertility. If you don't make good follicles, if you don't make a good primary follicle that will release a healthy ovum that can meet a sperm, then you end up with infertility issues. The other thing is, what I wanted to show you, the postponing of childbearing, which is becoming more common in this day and age, presents a new problem. We are in utero at about 20 weeks. A girl child has about 6 to 7 million oogonia, or follicles inside her ovaries, which are made through mitosis. At birth, due to this atresia and apoptosis that happens in your ovary, you then are born with only 1 million of these oogonia. As you continue to have apoptosis until menarche, when you have your first period, unfortunately, you only have about 300 to 500,000 follicles that can further produce a baby for you. And it's also said that with this increased apoptosis, when you turn 37 and above till menopause, you have less than 100 follicles that can potentially give you a baby. So women need to be very careful around childbearing if it is a desire. Not every woman wants children, and that's okay. But for women who do want children, it is important to plan your career versus planning also fertility and partnering so that you are able to get the best results for your life in general. So when you see women, please do speak about their period and do speak about childbearing, because when they come to us as 40, all they say is, I wish somebody told me. And we are that person who must told them. The next phase is ovulation. This happens through a surge in your luteinizing hormone to release a mature egg. If you look at the picture nicely, you see a growing follicle. Due to the high estrogen and your low FSH, you have a LH surge that is then promoted through the drop of the FSH and increased estrogen. The LH surge also coincides, if you remember, I told you your granulosa cells also become luteinized. Therefore, they are able to attract and pull more luteinizing hormone, which stimulates the ovulation. And again, the surge starts between 28 to 38 hours, and it peaks around 10 hours before ovulation. This is how we are able to measure luteinizing hormone peaks in order to try and assess if your patient is even ovulating during their periods. Again, this marks the fertile window. And after this, you have an increase in progesterone, which also gives you a mid-cyclic FSH rise, which is seen in the picture. As your FSH is rising, as your luteinizing hormone rises, your FSH also peaks in response to the fact that you've got a ovulation. So your LH surge also promotes the completion of your meiosis 1 and expels a polar body and starts to initiate meiosis 2, which is the more matured ovum that is able to meet with the sperm inside your fallopian tube. And when we have the rupture, it's literally the thinning of the rim and an enzymatic dissolution, which causes a breakdown of the theca and the luteinized granulosa cell and releases the ovum into your fallopian tubes. Clinical relevance here, we need to be once you have sorted out and figured out when your patient is ovulating, when they are trying to conceive, you need to then be encouraging them to be sexually active during day 12 to day 16. So 2 days before ovulation and 2 days after ovulation. And this is purely because, unfortunately, the human body doesn't read textbooks. So we may think it's 14 days, but it can be on day 13, it can be on day 15. We also know that your ovum lasts for 2 to 3 days inside the fallopian tube. Sperm lasts for 2 to 3 days inside your fallopian tube. So if you've given this woman day 12 to day 16, if she ovulates somewhere here in between, you've got something that can be fertilized and give us a baby. In terms of our luteal phase, this is after the rupture of the follicle and the ovum is released into the fallopian tube. This remaining structure that was carrying an ovum is now called our corpus luteum. It's the residual follicle which starts to collapse. It has more luteinizing of the granulosa cell and becomes extremely vascular. It becomes yellow carotenoid with lipid products, which has a very good steroidogenic cells that will help us produce progesterone. Again, this further preps the endometrium for implantation. If there's no fertilization, progesterone declines and your menses will start as previously shown. And then you've got what we call luteolysis, which is the breakdown of this corpus luteum. And that starts between day 12 to 16 post ovulation. If there's no fertilization, if there is fertilization, sorry, then the corpus luteum maintains the pregnancy till placental function is ready to assist. Thank you. So the other part, like I said, I believe in an HPOE system. This is our uterine cycle, which covers the E part of the axis. This also responds to the ovarian hormones that are released, which is estrogen and progesterone. The part of the endometrium which is actually shed is called the functional layer, which is the upper 2/3 of the endometrium, which undergoes proliferation, secretion, and degeneration. During the proliferative phase, you have re-epithelialization and revascularization. In the beginning, it's about 2 millimeters thick with narrow tubular glands. And this growth continues and peaks around day 8 to 10. The glands then elongate and widen. When you measure your endometrium, it will be about 3.5 to 5 millimeters. And most of this is through estrogen priming. If you remember, this is within that follicular phase where your follicle is releasing estrogen into the body so that it causes the endometrium to grow and to come back up so that it can hold a pregnancy. After you have ovulation, you have epithelial proliferation that stops 3 days post-ovulation. Then you have glandular secretions that accumulate. You have stromal edema where the cells become large and clear. And then you start with decidualization, which only gets completed when there is fertilization and it clings on to a pregnancy. So decidualization is literally propping up and fattening up of this endometrium so that it's able to start forming a placenta and start taking care of our pregnancy. Then the last stage is your degenerative stage, where there's a fall in estrogen and progesterone, which causes dehydration and shrinkage of cells. This also causes a leukocyte infiltration, which will give you a reason why we have leukocyte infiltration with tumor necrosis factor and a lot of inflammatory markers, which then causes hemorrhage. And then you get ischemia, necrosis, and apoptosis of the endometrium, which then allows what we see, which is the period. So the part that never moves is called your basal layer, and this has regenerative capacity post the bleed. So you don't lose your whole endometrium, you just lose the upper 2/3 of the endometrium. So in terms, I think, let's go into a bit of clinical applications also. So your cycle length is said to be about 21 to 35 days, most commonly about 28 days with ovulation on day 14. This will let you, when we ask patients, are you regular? meaning, are you having a period after a certain amount of time all the time? Is it cyclical in that way? If it's shorter, you need to worry about things like PCOS, thyroid diseases, premature ovarian insufficiency, patients who are actually on oral contraception, but probably not taking them right and end up bleeding earlier than normal. Some patients are on certain drugs which increase your chances of bleeding, like warfarin, clexane, those type of drugs. Then you also, some patients will complain that they have their period after 3 months. There you need to worry about things like stress, weight gain, or severe weight loss that can prolong your period because it shifts your hormonal profile and causes your ovaries not to behave in a way that allows them to have a period. Then you have an increase in N ovulation. Again, you must look at PCOS again here. And heavy exercising can also shut down your HPO system and not allow you to have a period. Looking at your cycle period, it should be about 3 to 8 days. Anything less than 3 days, you need to take a detailed history and find out what exactly is going on. You could be looking at anatomical problems where either there's some Asherman syndrome or there's some shutting down of that endometrium that's not allowing it to properly bleed out. There's anatomical causes that can cause a very heavy and long period, like fibroids, polyps, and adenomyosis, which is endometriosis found inside your myometrial tissue. Then you have endocrine causes, such as thyroid diseases, which affects your menstrual cycle. PCOS again, PCOS is always found everywhere, so I'm glad it's being done next week. Prolactin problems that can also cause an irregularity in your menses, and N ovulation due to stress, weight gain, and PCOS. So you also have medications, as mentioned, your COCs, oral contraception, the pill, anticoagulants, injectables. We know there are a lot of women who on depo can get a very heavy menstrual period or very long period. We know the Implanon has also been implicated in some of these complications where you have heavy bleeding, prolonged bleeding in women who have that increase of hormone inside their body. It's also important to ask about the amount. Obviously, every textbook says it's about 50 to 80 mils. It's very difficult for doctors, nurses, including the patient, to say what 50 and 8 mils is. But again, you go back to the pad use. So you need to check what is the culture of the pad usage. And if, like I said, if a patient is doubling, you need to worry. If a patient is changing pads, finishing a pack, you need to worry. But remember to ask. Some women are disgusted by blood. So every time they go and pee, they change their pad. So you need to find out, are you changing these pads because they are full, or you're just changing them because you don't like the sight of blood? Leaking is always problematic. So every time a patient says, I leak through my clothes, when I stand up, then I see blood running down at work or at school, we need to worry and figure out what the problem is so that we're able to assist these patients to have a better life. So there are common menstrual disorders that we'll look at: dysmenorrhea, abnormal uterine bleeding, amenorrhea, PMSing, and I don't think you can ever talk about the menstrual cycle and not talk about infertility or fertility. The first thing we'll look at is dysmenorrhea. Dysmenorrhea is severe menstrual pains that needs intervention. So we're not talking about taking a Panado because you're feeling a bit crampy, some Buscopan, but you're able to have a normal day. You basically have a normal life. But the minute you need hot water bottles during school while you are sleeping, the minute you need analgesia and you cannot survive without it, the minute you have such severe pain that you cannot go to school or you cannot go to work, that is a problem. And that is something that needs to be addressed more closely. So most women think period pains are normal. What's abnormal is how bad is it and what does it stop you from doing? Then you need to address it. But a little bit of discomfort managed by a little bit of Panado here and there is manageable. But once the patient starts complaining and feeling uncomfortable, then we need to check it out a bit closely. So you've got primary dysmenorrhea, which is without underlying pathology. It's usually familial, and it's from menarche, meaning from your most women will have it from their first period. And the thing is here, everything is normal. The ovary is fine, the hormones are okay, and the uterus itself has no abnormality, but they just get these severe pains. Secondary is with some type of pathology, whether it's endometriosis, adenomyosis, fibroids. PID can also predispose women to more dysmenorrhea during their periods. And in terms of management, you make the diagnosis, obviously, and you manage each thing as per the guidelines in terms of both endometriosis, fibroids, and all of that. But the biggest things you can give is NSAIDs. Remember, I told you your period, that desloughing and the menstruation is an inflammatory process that releases cytokines and releases prostaglandins. So we give you NSAIDs to try and block off that pain. There's hormonal therapy that we use also, your COCs, they work like a charm. And they are also, they will also then help with other parts of dysfunction, whether it's heavy bleeding, regulating the period, and they also find that they also decrease period pains. And again, lifestyle changes. If your patient is obese, advise them to lose weight. It goes a long way. Healthy living promotes healthy hormonal processes, healthy periods. Exercise also goes a long way. Therapy, guys, especially for patients where there's nothing we can find to remove the dysmenorrhea. Patients need to then be guided and educated about their period, educated about different ways how to minimize the amount of pain they are feeling, and then helped out with other parts of their life so that they are able to have happier lives. The other big problem is actually one of my favorite topics, abnormal uterine bleeding, which is the heart of obstetrics. I mean, of gynae, not obstetrics. So you find women with heavy menstrual bleeding, oligmenorrhea, meaning a small period, intermenstrual bleeding, meaning you have bleeding and spotting in between your actual period, post-sex bleeding. This is a very big problem. You shouldn't be bleeding after sex. And if you are, it's something that needs to be looked into. So in terms of causes, the best thing to use is your palm coin, where we look for polyps from whether it's your cervix, whether it's the uterus itself, where we look for adenomyosis, which is endometriosis found inside your myometrium, which is the muscle of your uterus, leiomyoma, which is fibroid, which is big growths that are found around the uterus, malignancies. When you find, especially when you get spotting and continuous bleeding, make sure you put in a speculum so that you can see, is this cervix normal? So that if there's an abnormality, it can be addressed as soon as possible. Coagulopathies, the most common one in South Africa, in Africa, we know is von Willebrand's disease, but you can also get things like factor 8, factor 10, and all those type of deficiencies that don't allow patients to clot. You can also get ovulatory dysfunction, of things like PCOS. You can also get endometrial dysfunction, where the endometrium itself is unhealthy and it's not responding well to the hormones. That can also be addressed and checked on. When you look at endometrial, always think of endocrine also, where you look at your thyroid and you look at your prolactin so that you are able to check that those are normal and able to address them appropriately for your patient. And then unfortunately, there's not otherwise classified, meaning we actually don't have a diagnosis. This woman just bleeds heavily. Then you need to manage the symptoms, minimize the bleeding to the best of your ability, and counsel the patient again. Again, we have hormonal contraception that we use, anything from your oral contraception to manage these symptoms. Oral contraception, remember, we're literally just regulating your cycle, giving you the right amount of hormones at the right time in order to produce a better response of your endometrium and your menstrual cycle as a whole. Then you have things like Depo, which actually can, for some women, shut down the period completely. If it's too heavy, then maybe it should calm down a little bit. We'll call it back when we want a baby next time. You have things like the Implanon. For some women, it also causes iatrogenic amenorrhea, much appreciated if you're not trying to have a baby. And then you also have things like the Mirena, another diamond in the rough out here. Once we put in a Mirena, a lot of women, their endometrium is able to calm down, and some women end up with amenorrhea, some women end up with a less heavier period, and there's no back and forth going up and down in a hospital trying to get assistance, collecting your medication, and it's quite a good contraception and uterine bleeding stabilizer. So again, we give cyclopentone when you have the heavy bleed to help your body to coagulate and stop the bleeding. NSAIDs to manage the pain, to also, again, it is just an inflammatory process, so you just need to shut it down. And then depending on the cause, you then need surgical intervention. For things like fibroids, you've got myomectomy, which is just removing of the fibroid. You've got beautiful things happening at Bara called HIFU, where they literally shrink those fibroids with some electrical waves from your MRI machines. Then you've got hysterectomy, where you can literally remove the whole womb. Once the mommy says, I'm done with children, I'm happy, you can take it out. That's also an option. And if I do the presentation on AUB, we can then grossly go into this information. Then you have amenorrhea. There's primary, where there's failure to start a period by the age of 16. At this point, you need to investigate this child, and you need to see if what is the cause. It can be hypothalamic, so from the brain. It can be in the pituitary failure that you need to investigate. It can be ovarian failure. It can be a whole Mullerian agenesis, where there is no uterus, there is no ovaries, or there is actually Mullerian dysfunction, where you've got a thickened hymen that blocks the period from coming out into our view. You can have, what are these things? Oh, a transverse septum that can also block the period from actually coming out for us to see. But those patients will then present with cyclical pain and an enlarging abdomen without a period being seen. Those will need further investigation. Then you've got secondary amenorrhea, which is absence of a period for 3 or more months. And then the cause needs to be sought out. So for patients who are on depot, we know the cause, it's iatrogenic, it's the doctor and the depot. Mirena, Implanon, we know the cause, iatrogenic, it's the doctor and the contraception. But for women who have not taken anything, they need further investigation. And again, you check your thyroid, you check the hormone profile, you check the anatomy to make sure everything is in order, and you are able to then treat the cause appropriately, stimulate with hormones, and then surgically remove anything that is blocking, which would be the hymen and the septum, surgically remove or reconstruct some of the anatomy in order to allow for the period to actually come back or arrive. And then you stimulate this also with hormone, as long as you've identified that all the structures are normal. So in terms of causes, Mullerian disorders, PCOS is a big problem. Hypothalamic amenorrhea, which goes with all other congenital abnormalities that can be spotted on site, thyroid diseases and prolactin diseases. Again, I'm sorry I didn't mention counseling. Patients must be counseled so that they understand the problem. Therefore, they can keep up with your treatment, keep up with your follow-up, and plan for their future fertility and way forward with their families. I think we don't discuss PMSing enough because we think women are dramatic when they're PMSing. I think we are, but hey, it is quite a difficult thing to experience. This is premenstrual syndrome, or PMDD, which is actually such a severe and debilitating experience, I should think. So in terms of symptoms, it's the mood swings. 1 minute you're happy, then you're sad, then you're crying, then you're sensitive, then you're dramatic. It's a lot. Then easily fatigability. There's irritability, and there's a lot of emotional irregularity. There's also quite a lot of GIT symptoms where the women are bloated. Some women even present with diarrhea. Some women present with severe constipation. And then there's also breast tenderness, which is expected, but for some women, it can be so painful, so debilitating, so uncomfortable that it causes them to be unhappy. Then with your PMDD, it's a more disabling form of PMS. So most women with PMS can cope. If you know your cycle, you know it's coming, your family knows it's coming, you're able to excuse yourself from certain events, from certain spaces, and everybody knows to be a little calmer with you, a little forgiving with you. But with PMDD, it can be so debilitating that it actually needs medical intervention, needs a psychiatrist, needs a psychologist. And then again, you need to give an extensive education to this woman so that she's also able to avoid things that worsen the situation and use things that are more promoting of a better life. So lifestyle modification, dietary changes are important. She must know what makes her PMS worse. So there's no one size fit all. Each patient must be taking a good history and find out what worsens her symptoms so that she can avoid certain things and what makes it better. I know a lot of women will say, when I go to gym, I feel better. I know some, when I see my bestie, I feel better. When I get a hug, I feel better. And then we're able to sort of help them find things that help them to feel better. Then obviously hormonal therapy again, oral contraception to try and regulate your hormonal state so that you are a little bit more balanced. And then cessation with rest periods. So if you put a patient on COCs, especially young people, if they have severe PMS or PMDD, you want to stop the period completely. So you then make sure that during the school holidays, they go on to the part of the pill that allows them to have a period, and then they are able to at least re-regulate their cycle and have a better experience. But when they are at school or have heavy projects at work, then we seize the period to try and minimize the symptoms of the PMSing. And then again, like I said, psychotherapy is very much recommended, and a psychiatrist, if you've got PMDD, is also indicated, and then they will prescribe SSRIs and all sorts of antidepressants and other coping drugs to assist. So here, refer, make the diagnosis, refer. If you are in the clinic, refer to a gynae. And when the gynae has managed the period, manage the psychological elements, add your dietitian, add the gym, and find out what the patient likes to do and increase their happy drugs in their brain. Menstrual irregularities and PCOS, I'm glad this is being done next week again. It causes chronic anovulation, which leads to irregular menses. Signs, you see women with short beards, with mustaches and amahwang, hair on the sideburns, I think they call them. And then, so basically, they have hair in male patterns. So where your husband or your boyfriend has hair, you now as a female also has it. You have acne because of the hormonal production produces just oily skin that predisposes to such terrible acne. There's also a higher rate of obesity, and the obesity further aggravates the PCOS, further aggravates the ovarian dysfunction. They also get insulin resistant, which predisposes them to diabetes. And unfortunately, they end up with subfertility or infertility if it is not well managed and redirected in terms of that. These women are also more prone to depression. They are more prone to endometrial cancer because of just this whole milieu of this PCOS, which will be presented next week. So excited. So basically, in terms of us as clinicians, make the diagnosis. To make the diagnosis is very much clinical. The patient will give you the presenting complaints. Looking at her, you will see the obesity. You'll hear about the insulin resistant. You can find the acne, the hirsutism. That will give you the clinical diagnosis. You confirm on ultrasound with finding polycystic ovaries, which we say that it's like your ovary is wearing pearls because it has these small little ovaries next to them. If you remember from the follicular phase of the menstrual cycle, you have these small follicles that start growing, but they never actually mature. And if you remember, I did say that when you have a high androgen level, you then have poor follicular maturation, which is the disease that propagates all the complications of PCOS. You then need to find out what are the fertility needs of the patient. I mean, I saw today a 14-year-old with PCOS. She's not trying to have a baby. She just wants a regular period. You manage that, but you need to discuss fertility and understanding with the family so that they are prepared for the future and they don't leave PCOS untreated because it's not causing that much trouble. And then if it's an older patient, a patient who's currently seeking for a baby, you then need to regulate that period. If you then you start you can give Clomid, letrozole, you start controlling the insulin resistance. Basically, I always say as a gynae, you have 3 months, 3 shots at trying to save the patient. If you fail, as a brief doc, send to the reproductive specialists, you've done your part, and allow them to move more swiftly and more aggressively and more goal-directed so that patients get babies. Don't sit as a gynae with the baby for many, many years and there's no baby, but the mom is unhappy. Manage all the comorbidities, do all the screening of the endometrium, of the diabetes, and treat appropriately. Prevention, prevention, prevention through lifestyle modification. Menstrual cycle and fertility, again, we see a lot of women because they just are trying for a baby. So once you get your patient to then track their period, find out when their ovulation is, you optimize their chances of falling pregnant. Like I said, during the ovulation part, day 12 to day 16 is your most fertile window so that you are unable to fall pregnant. Again, I find a lot of patients, they want a baby, but they're not having sex. Sometimes you have a normal period, you have a good tract that is available, but the partner and the couple is just not having enough sex. Before you say somebody is infertile, make sure you are finding out, do they stay with their partner? How often are they having sex? And then make sure you also find out, does their partner have other children? And how long have they been trying? You find a lot of young people, I mean, I've seen 23-year-olds complaining of infertility, but they've only been dating for 6 months, only sexually active for 3 months. So you take your histories, guys. Don't jump the gun. Don't give Clomid for everything. First, find out, fix the patient in front of you, which is the female. Fix the couple. Make sure they are doing well as a team. And then add drugs if they are unable to see relief. Young patients, you've got time. From 30 to 35, try to move swiftly and refer in time if you're not winning as a gynae or as the clinic. And then 35 and above, I say reproductive specialists, the quicker the better. Remember to refer early to your specialist, so your clinics refer to the hospitals quicker. And then from your gynaes, the nurses refer to gynaes, gynaes refer to specialists. Remember, investigate the tubes. If you have a good menstrual cycle, it's irregular, it's not heavy, it's not troublesome, but you're not falling pregnant, there's still a big problem of tubal health that we don't talk about enough in this country. Our increase in STIs, increase in HIV means our tubes are blocked and therefore our women are not falling pregnant. But also check the partner, do the sperm analysis. Is he producing sperm? Is the sperm healthy? And then try to put the team together and allow them to have a happy family with your assistance. Again, gynaes, don't forget to refer to the reproductive specialists very quickly, and let's make the magic. Menstrual cycle and contraception. So you have to realize anything you put in the body can affect you. So hormone contraception have an impact on your cycle. Like I've said, Implanon can cause heavy bleeding, can cause amenorrhea where you don't have a period at all. COCs, if you forget taking the pill or taking it every 3rd day, it can then cause you to end up with spotting, irregular periods. It can also actually increase your fertility and you end up pregnant because you are creating a hormonal profile that allows an LH surge at a random hour, and then you end up falling pregnant if you are not having safe sex. And then things like depo again, heavy bleeding, amenorrhea. And then we must remember to talk about the side effects. A lot of women stop our hormonal contraception because they are worried about weight gain. And then what I tell my patients, pick a struggle, baby girl. You wanna a baby that you don't want, or you'll take a little bit of fat, a little bit of gym, and a little bit of healthier eating. Most women refer to a dietitian, encourage some walking, they will follow your guidance. Young people, I always encourage them. If I start a young lady with PCOS or irregular menses or dysmenorrhea on COCs, I then tell them that it will give you gorgeous skin, girl. And you'll see young patients will take it like clockwork, because there's nothing a teenager hates more than pimples. Again, counseling. Patients stop medication or do wrong things because they don't understand. So it's on us to explain, to guide, and please, doctors and nurses, be in the habit of drawing. It makes so much more sense. Emergency contraception, very important to remember timing. You have 72 hours from the time of mistake to take an oral emergency contraception, and then you have a maximum of 120 hours to then receive an copper IUCD as an emergency contraception. In terms of effectiveness, you need to discuss this very well with your patient. If you are late, it won't work. If you are on time, there is hope. But also remember to tell them that when they take the oral, it can then cause a heavy period and sometimes even a prolonged period. Again, once your patient is well counseled, they behave better and they stick to your plan. In terms of intrauterine devices, they can cause cycle changes. We know the side effects are things like spotting, that's with your copper, and then amenorrhea with your Mirena and your Chialinis. And then we know that it can also, if you also need to, once you put an IUD on a patient, you need to motivate them with their sexual health. You cannot be having an infection and not getting it treated, because whatever is sitting in the vagina can then go up and sit on our Mirena. And there's a big problem of actinomyosis, which is very difficult to treat. Once it's sitting on your IUD, you then need to extract that IUD, and that can be have cost implications for the patients. Again, counseling. Our patients are as smart as we allow them to be. If you counsel them, they'll behave better. If you take a good history, they give good information. So again, unfortunately, it lies with us as the clinicians. Menstrual health and adolescence. So the most important thing to note is menarche. The normal age of onset, like I said, is 12 years old, but you're looking at anything from 9 years old till 16. If you reach 16 and there's no period, you need to investigate the patient and figure out what's wrong. If the period appears before the age of 9, that is precocious puberty. You need to investigate and see what is going on. Also remember to look at all the other tenor staging, the breast, the hair allocation in the body, and then you're able to make a decision on what's the best way forward for that child. Adolescent consents to be wary of cycle irregularities. Remember, the first year of your period can be quite irregular. So you need to counsel the patient about this, but if it's troubling them a lot, definitely do add an oral contraception to try and regulate that period. Painful periods, as we've already discussed. If they are troubling them so much that they're unable to go to school, you stop the period, they can have a period during school holidays. Pregnancy, I have a lot of teenagers, unfortunately, in my clinic. It is happening. A lot of young people are sexually active. And if we are not educating them when they come to us to consult about their period, then we are unable to protect them. Nurses in the public clinic, nurses even in private clinic, when young people get brought to you, even if they are coming there for a cough, remember to ask something about their period and try and advocate for some type of contraception. The earlier the children are informed, the better they behave. We're not encouraging sex, we're just protecting our children from unwanted pregnancies. And it gives you an opportunity to also discuss safe sex and allow for less STIs, less HIV, and less complications related to that. Sports and its effect. when I was a teenager, I loved it when the period went away because I was so sporty. But it's also not a healthy thing. It's something that you need to look into very clearly for the patient, get them on a oral contraception, because you don't want future problems of a period that was not well regulated. Sports on its own cannot be what's stressing the child. They can have other mental health related problems, which further depress their hormonal system and depresses their periods. PCOS is a big problem. PCOS, you have it from a very early age, treat it early, regulate that ovary so that by the time you are ready for fertility, you have better chances. Treat stress, manage depression, and all sorts of anxieties that our young people are finding amongst themselves. Healthy menstrual habits, hygiene, hygiene, hygiene. So important. Advise on pads. If they end up with irritable skin, then they must use more sensitive related pads, not the plastic related pads. The whole issue of virgus intactus, a patient who's not sexually active, and tampons. That's a very common questions we get asked. And I mostly advise the young people, don't use the tampon, because for them, it feels like something has already happened and it's an actual uncomfortable. So pads are more promoted. We've got the cup that is now available, which is also nice to use for young people. You've also got padded underwear, which acts as a pad. So there's no changing. The pad itself is able to accumulate quite a lot of blood before you need to change it. And all of these are available on Instagram for all the cuties. So again, this is an opportunity to discuss tubal health. Sexually active young people end up with lots of infections. They are scared to tell their parents, so they don't get treatment. And then you have tracking up of these infections causing PID, tubal or occlusion. And then by the time you're 28, married, happy, trying to conceive, dololo ama tubes. So it's something we really need to look forward to. So I draw everything, I explain where a baby is formed, so that I also encourage you to protect this tube. I have straws in my rooms and I show you this is how thin an actual tube is. Once it's damaged, nobody's able to operate it. So protect this thing like it's your life depends on it. And then early help-seeking behavior, infections, they must come see us early, contraception counseling and encouraging. And any patient that is more understanding of their body, they are more reassured and they are more empowered. And I encourage all the nurses in the clinics, all the nurses and doctors in the state hospitals, you have to try to be kinder when it comes to discussing sex and contraception with our young people. A lot of them don't come to us because they feel we are antagonizing, we are bullying them, we are scaring them. If we want to protect them, if we want them to have a better future, we're going to have to inform them. When they do come to us, we cannot miss that opportunity just because we are scared as parents, scared as older sisters and mothers. We need to do better. Scared even as the male practitioner. It might be an uncomfortable conversation, but once the patient is in front of you, it is your duty to educate, to empower, and to allow for a better outcome in that young person's life. Menstrual health with perimenopause, eventually this period is going to go away. And during that, you have a lot of discomfort. Hormonal fluctuations would lead to cycle irregularities. So in terms of symptoms, the mummies are complaining of hot flashes, night sweats, mood changes, dry vagina, and a lot of, they also predisposed to more UTIs. So we need to control this period. In the perimenopausal phase, they can also experience lots of heavy bleeding. They can experience the anovulatory phases with amenorrhea and then a heavy period. I like to tell the mummies, this is just your body preparing to stop the cycle. So sometimes it gets a little bit moody as it's doing it, and we need to be patient. Don't forget, you need to exclude any endocrine causes. So make sure your thyroid is normal, make your prolactin is normal, and exclude any hyperplasia and malignancy. Do your ultrasound, look at that endometrium. So once the woman is still having a period, unless you have a big fibroid or a big polyp inside your endometrium, there's really nothing much to see. Therefore, we encourage you to do endometrial samples. using a Z sample or take the patients to theater and use the gold standard, which is a hysteroscope, a focused biopsy, and then you can still do a DDNC just in case you missed something. And I mean, there was a topic recently on hysteroscope, and there's a drive to more specific endometrial extraction to allow for diagnosis and management of endometrial diseases. All your women who are perimenopausal, as a belief, mammogram. Encourage women to do self-examination. So because women will pick up the problem first, partners will pick up the problem first. The earlier we find it, the better the outcomes for everybody. And then obviously HRT. Mammograms, because we cannot give HRT without a mammogram. Lifestyle modification, again, losing weight goes a long way. Healthy lifestyle, exercise goes a long way. Again, I said there's lots of mood changes. Perimenopausal and menopausal women are more predisposed to anxiety, depression. Psychotherapy is king. Once you start menopausing, the children are older, the children start going to universities, just you and your partner. Some people lose their partners in the time. There's a lot of stress and a lot of strain upon their lives. Psychotherapy goes a long way. Again, remember, perimenopausal women are still lively young women. I mean, if you are 40, 45, you're still sexually active. Find out how their libido is doing. Encourage, once you give hormone replacement therapy, it also helps with the libido. And then encourage lubrication. I love it when my patients come with their partners, because then I'm able to explain what perimenopause is, explain the vaginal dryness, explain the mood swings, explain the libido dropping, and then encourage them as a team to do better as a team in terms of finding more ways to elevate their mood and to get the job done. And in terms of our red flags, the first thing I think is important to understand is the limitations of your institution, your ability to investigate, and your ability to treat. So it's very important. A clinic, you don't have, most clinics don't have, some clinics don't have ultrasounds. You don't have a CT scan. You don't have endometrial samples readily available. Pap smears you have, we thank God, and please do that for our patients. But once you have examined the patient, once you have taken a history, refer as soon as possible. Don't sit with patients and give them COCs time and time again. If you give COCs and it's not working, please refer as soon as possible. If you're not sure what's going on, refer to the next level of care. So the red flags that we need to look out for: no period before the age of 16, a period before the age of 9, you need to refer those patients. Irregular periods after 1 year of menarche, you need to refer. We need to see what is the problem. Severe dysmenorrhea, purely because it's such a life-changing experience. And if we can help you, then refer and we treat if there's any pathology, and then we allow for hormonal therapy to manage the symptoms. Severe PMSing, irregular cycle with endocrine features. So if there's a thyroid, whether it's hyper or hypothyroidism, hyperprolactinemia or hypoprolactinemia, insulin resistance, diabetes, any other endocrine problem, refer so that we are assisting these women to manage their cycle and to get a better fertility structure when it's needed. Regular period with infertility. Remember, I said, you don't just need your period to fall pregnant. You need good, clean tubes that will push the pregnancy back into the uterus. So when you have a regular period, good sexual contact, but you're still not falling pregnant with this patient, refer. Heavy menstrual bleeding, abnormal uterine bleeding, palm coin, refer. Amenorrhea, oligomenorrhea, refer. Suspected malignancy, refer. Menstrual health and the society. These are myths that I am so ready to dispel amongst the community. Your period, I know a lot of people will say your period is unclean. And I even went on to read, they say even in the Bible, it is a reference made on religious basis, whether it's the Bible, the Quran, or whatever, where they believed women were unclean. If you read further on the matter, It was because back in those days, there were not a lot of padding or tampons used. Therefore, women would end up bleeding in church, and then you end up dirtying the place that you are in. So the uncleanliness was not to say the blood inside of you is dirty. It was to speak about what becomes once you have bled on yourself because you're using a cloth. Cloth cannot hold blood for long. Therefore, if you are sitting there at Postoli or these churches that can run for long, then you're sitting there and you're bleeding on yourself. Therefore, it was viewed as unclean, not to say, and thus they would say women mustn't come to church on their periods. Even other societies have also adopted that type of mentality. But today we have pads, we have tampons, we have cups that can hold blood for longer periods, and then women don't have to feel unclean. Again, your period is a friend, not a foe. Your period is your future babies. Therefore, it is a friend. You want to see a period. And your period also means you're not pregnant if you were not ready for a baby. So period is a friend, not a foe. Remember, no period, no baby. Also, your period is a sign of a healthy, balanced hormonal and reproductive system, which is the ultimate desire for all women, because by the time you want it to reproduce, you want it at its healthiest. And then remember, iatrogenic amenorrhea, which is caused by your doctors and your nurses by giving you your contraception, whether it's Depo, whether it's Implanon, or it's the Mirena. Those are the other things that cause amenorrhea. And there's this myth where they say that if you are not bleeding, it means the blood is going to your back, it's going to your brain. That's what's causing you to become feisty and aggro. Hi, guys, there's no such thing. Basically, when you're not having a period from iatrogenic amenorrhea, your ovary has gone to sleep. I tell my patients all the time, you must just come down, that ovary has gone to sleep. It's not stimulating the endometrium and it's not allowing for you to bleed. So there is no pathology or misnomer happening to you. And then obviously contraception myths are things we need to deal with. If you use contraception, by the time you want a baby, it won't happen. We need to discuss which contraception is best at which age and at which reproductive desire, so that we give you what works long-term, but is reversible if you are still young and desire fertility. But if you are now perimenopausal, we can give you something that's more long-acting that won't need to be stimulated to give you a baby again. So talk to your patients, allow them. I always ask, what are you afraid of? And whatever you are afraid of, I try to dispel the myth with information and education. Teenagers, this one is the bane of our existence, and sex myths. I mean, I was listening to a talk recently where they were saying teenagers must be given reproductive freedom, and went all the way to allow them to reproduce. There's a lot happening in our country. There's a lot happening in the world we are in. So we need to address issues appropriately, educate and empower young women to understand what their period means to them, how it works, where babies are made, how to protect these reproductive systems that God has given them, so that by the time they need to use them, they are readily available and healthy. There is no greater healer than information and education, colleagues. And we are the bearers of the information. We should share it with our communities. And then in terms of practicality, guys, I think it's so important. I mean, half of the things written here, I have reiterated and reiterated. History taking is the diamond and the gold of medicine. I know the more specialized we get, the less we talk, and the more we cut, the more we put probes on patients, speculate, the more we investigate the patient without actually talking to the patient. And that needs to it needs to stop. Talk to your patients. The diagnosis, I remember in medical school, they used to say, if you finish your history and you don't have a differential, your history was poor. If you do your examination and you don't have a diagnosis, your history was poor. So you must start with 10 different things you are thinking of. You examine, you must drop to to 5. You investigate, you must drop to 3. You get your result, you must have the one diagnosis that is trying to assist you. And that comes with practice, that comes with time, that comes with talking to patients. Also be friendly. They say gynaes don't smile. They are so serious. Hi, guys, smile. Aibo, you're about to talk about the most sensitive part of a woman's body. Can you just relax a little bit so that they're also able to give and share information in a way that it allows you to do your job best and earn those rands and dollars, colleagues. Cycle management, talk about PMS. I mean, a lot of women think it's normal, but it's treatable. So let your patients tell you what troubles them so that we are able to assist them. HRT and other drugs. A lot of women menopause and they don't know they can be assisted with the hot flushes. They can be assisted with the dry vaginas. They can be assisted with the libidos. Talk to patients, find out their problems, and let them tell us how to help them. And then in terms of our examination, don't forget to check your thyroid. Don't forget to check your breast. Don't forget to look at the eyes and look for any abnormalities, because you can see even any exophthalmos of the eyes. Check if the patient cannot see the side of the eyes. That gives you ideas of some of those brain lesions that they can have. Tenor staging on young patients. Look at the breast, look at the armpits, look at the vaginal hair growth, look at the height, look at any, it's not a nice thing to say, abnormal looks on the patient. Abdominal pelvic examination, touch the stomach, find any masses that are there, and it helps us make a diagnosis. A lot of patients hate speculums, hate vaginal exams. What I find really works, I show them what a speculum looks like. I tell them that they need to relax so that when the speculum goes through, it doesn't pinch them. And then you tell them, take a couple of deep breaths so that when I'm in, I do what I do, I come out, it's quick. But if you're squeezing, you're closing, you're fighting me, you're going to experience more pain than necessary. And the other thing that helps a lot, talk to your patient. Ask them questions about their children, ask them questions about school, just so that they are less expectant and rigid when you are examining them. Don't forget to look for signs of anemia. And in terms of your investigation, hormonal profile is key when you're looking at menstrual dysfunction. FSH, LH levels, different parts of the cycle. The nice thing about the labs, they will tell you how much hormone to expect in each part of the cycle. Therefore, it makes it easier for you to make a diagnosis and find problems. Thyroid must be done, prolactin must be done. Obviously, if your patient is bleeding heavily, you want to check their HB so that you're able to boost them. Look for iron deficiency anemia, which is very common, which goes with heavy menstrual bleeding, so that you can give them the iron, give health education, and allow them to make more iron. And then do your ultrasound, CT scans, and MRIs. I mean, I recently had a patient who had an imperforate hymen, and between me, Dr. Billy, Dr. Randy, Dr. Olivia, Dr. Bongi, figuring out whether I should do a CT versus an MRI, it is a lost. Mammograms are extremely important, colleagues. Pap smear and HPV testing, the guidelines are continuously changing. Make sure you're constantly reading. And then in terms of management, treat the cause, educate, and extensive counseling. Family planning is so important in this day and era. So it's our job to ask, it's our job to educate. Even if somebody didn't ask me, you will be told about COCs, you will be told about injectables, you'll be told about the implant, you'll be told about intrauterine devices, and I'm the queen of long-acting reversible contraception, but I want IUCDs in everybody because there's less admin, and in terms of side effects, I find them a little bit more manageable. Find your niche and encourage your patients towards it, but listen to patients and try and work around their needs as best as you can. And remember to follow up on patients. Let them come back, check up on them. Once you start somebody on a treatment, don't just send them off and trust that God will do the work. Bring the patient back, find out if there are any side effects, find out if there are any other needs that you can address accordingly. And then know when to refer and be quick, guys. Nurses refer to the gynaes, and then gynaes refer to all the subspecialties that are available to you, whether it's reproductive, whether it's oncology, whether it's fetal maternal. All I'm saying is refer. And don't forget to use multidisciplinary teams. Use your endocrine specialist to assist you in managing the period, managing endocrine-related dysfunction. Autoimmune diseases also cause a lot of trouble around our periods. So work with their physicians, work with your endocrine specialists, work with the gym instructors, work with your psychologists, work with your psychiatrists, and let's get better health for our women. And then future topics I thought I really would like to see is abnormal uterine bleeding, amenorrhea, because these are, I mean, as much as I kept dabbling into them and mentioning them, they're actually very big topic that needs concentration into them in terms of how to follow them up, how to diagnose them, and how to assist our patients moving forward. Menopause, I think menopause, we treat it like it's normal. And a lot of perimenopausal and menopausal women are actually suffering out there and they need our help. Therefore, we need to be more informed so that we're able to help. Adolescent gynae care, guys, you realize as you start seeing more young patients that you haven't actually seen enough teenage vaginas, enough childhood vaginas. Therefore, when there's a pathology or a problem, even you look and you're like, yo, okay, what am I looking for? What am I not looking for? So I think the more adolescent gynae we do and we speak about, the more we can do to assist them. Involve your pediatricians. They are the ones looking after our children. And once they are referring to you, use a multidisciplinary team to assist each other. Infertility, oh, such a sad problem in our country. So it's something that we also need to look into. And then PCOS is coming up next week, so I'm super excited for that one. And then these are my references. Ngiyabonga. Any questions?
Hey, Dokotela, don't you want to sip some water? That was awesome. An awesome marathon.
It was really well.
Yeah, before I ask for David and Billy's comments, colleagues, thank you very much for joining us. I think this was very, very awesome. I see most of you are asking about recordings and stuff. Join, become a member. If you're a member, you don't ask because they are always uploaded on the platform. Also, to you again, Dr. Nomshato, we are not going to have a PCOS webinar next week. We have a micro lesson on PCOS. So we are just informing our members and reminding them because this month we are just focusing on gynae stuff, so saying, hey, there's a lesson that you can take on PCOS. So I'm hoping we'll have another one with you at some point. Yeah. David, would you like to start? I don't know, Billy, David, your comments, and I don't know how far we will go with the Q&A, but colleagues, stay put. Let's see how far we can go. But this was very awesome. Thanks again, Doc. Yeah.
Thank you, sir. Thank you so much.
Thanks, Shadow. Yeah, it was awesome. It was brilliant. I'm looking at all the reactions. Yeah, people loved it. And I think the way it was so good, people have not even been looking at the clock. So it just says, and the passion is really, really appreciated. David, your brother, there maybe your comments and maybe just help with some of the Q&As. I've tried to sort of answer some of them, and I see David is also trying to sort out some of the answers. And unfortunately, colleagues will not be able to answer each and every question that is being asked, but we'll try and do as much as we can. Please let's sort that out as well as David. I'll try and be typing for the other colleagues. Thank you. David?
Yes, Billy, thank you very much. Thank you very much, Doc, for a very good and informative presentation. I think these topics are very much important because we know that our profession revolves around the menstruation cycle. Whether it's in obstetrics, it's definitely the results of the menstruation cycle, or whether the most complaint that we also see in gynae, it's mainly revolving around contraception. I just wanted to highlight two things. I know you have briefly spoken about it. Just for colleagues, especially with the one thing that I came to realize, I am spending much time of my time reading on reproductive medicine, and there's actually more that you learn every day, and you just realize that you only know so little. And the one thing you highlighted, the issue of follicular and the luteal phase, and it is proven that the follicular phase it varies, but the luteal phase is very much fixed, and that is why the history taking is very key. And most of the slides that you highlighted, they were mainly of a 28 cycle, especially for us in the gynae. We speak about this testing for ovulation, this day 21 of menstruation cycle is to assess whether there has been ovulation. And actually most of, especially some of the colleagues that I see now, they're actually saying that there might not be a need, especially for someone who has a regular, frequent menstruation. Because the only reason you end up with bleeding, it only means one thing. It means that you should have ovulated, you should have had a luteal phase, and that is already probably a good sign to say that that woman is ovulating. However, should you really want to take those days, you must be taking the cycle into context. For example, someone who has a day 35 cycle, you can't be doing a progesterone test on day 21. You have to do those tests maybe a bit later, because you may actually do it prematurely and you interpret that as if someone who is not ovulating. And for that patient, one maybe will consider to do it on day 28. The other one that I just wanted also to highlight is the related to abnormal uterine bleeding. And you correctly mentioned there that not otherwise classified is one of the causes of classification in terms of the palm coin. And in the brackets there, it showed the ethmosil or the cesarean section defect. And especially in modern obstetrics, we having an increasing globally prevalence of cesarean sections. And the end result of what we see in gynae is abnormal uterine bleeding. And perhaps in the near future, we'll find that as part of the palm coin, the cesarean section defect is probably going to be incorporated. But for us, we need to be assessing, when we are assessing these patients, we must be intentionally looking for the cesarean section defect, as it can be actually the cause of menstrual disturbance, whether it is premenstrual, they may have issues related to heavy menstrual bleeding, they may have post-coital bleeding, or they may have this ongoing irregular, unexpected intermenstrual bleeding. So it is actually, when we assess these patients, we really need to do a good thorough ultrasound. One may also even consider to do a saline sonohysterography to assess if there is any signs of that will help improve your sensitivity in diagnosing these patients. I think it's just something that you really need to be aware of, especially in modern day practice with an increasing rate of cesarean section. Otherwise, I think the presentation was very much informative, and I think thank you very much. We're just going to look at some of the questions, and there are quite a lot, and we'll try to answer as much as we can. There is a question on a 28-year-old on Implanon. She consulted for period pain on day 3 with nausea and vomiting. Should we be worried? I think the question is not very clear whether it was 3 days after the insertion of an Implanon. If that is the case, it is unusual. It's unlikely that it is Implanon that is causing nausea and vomiting. Day 3, I'm not aware of that. Billy, can you comment on that? I think this patient must be considered for other causes of nausea and vomiting.
I agree with you, Dr. Mbula. It's not
Yes.
common to have nausea and vomiting.
Yes, it's not.
And I have found that patients who had an Implanon were actually already pregnant.
Yeah,
Because
or
sometimes
maybe she was
don't
pregnant,
do,
yeah.
yes, don't do the pregnancy text prior. Patient says, no, I had a period last month. Or I'm not sure what the process becomes, but if we don't do, like I get history, and then you put in an Implanon, you have nausea and vomiting, most likely that patient might be pregnant. But you can also look for infections or anything else that can cause that, and then treat. I mean, they can have UTI, PID, there could be anything else happening there.
All right, good, thanks. The next one is the patient with cycles of more than 40 days and irregular. How do we prevent them to determine their fertile period and when trying to conceive? If someone has periods that are going beyond 40 days, by definition, this is pathological. It is not normal. As Doctor highlighted earlier, that it is up to about 35 days, what is considered to be normal. So in this patient, we need to wake up the patient to try to find out what is the cause of some this prolonged period, as it can vary from having endocrine issues that are related to thyroid, prolactin, and many other endocrine condition, to simple condition like Doctor highlighted of PCOS. So once we then made a diagnosis, and if it is, for example, the most common cause of this is usually patients with PCOS, you can actually put them on a basic COCs that you will use as the reference on when you start with ovulation induction. And when they start bleeding, usually we start an ovulation induction between day 2 and day 3 of their menstruation cycle. So you can use the COC as a reference cycle, as a reference. But the most important thing is that we need to make a diagnosis on why they are having these irregular, prolonged of periods of amenorrhea. Any comments on that?
No, I agree.
And then the one is hyperprolactinemia as a cause of amenorrhea. What is the mechanism? And again, this is it has to do with an impact of, is it hypoprolactinemia? Is it hypo or hyper? I'm not aware of hypoprolactinemia. It is hyper.
Hyper.
And if yes, it is hyper, and it has to interfere with at the level of the hypothalamus, and that it's a negative feedback, and that definitely has an effect on the pulsatile release of the gonadotropin releasing hormones and the gonadotropins release thereof. And without the FSH release properly, then there will be lack of menstruation. It is mainly have to do with the negative feedback. And that is also the same mechanism how you get menstrual abnormalities with the thyroid. It has to do with the negative feedback. Any comments if it's hyper? I think maybe it's a typo error. It should be hyper.
Maybe hyper is the obvious one.
Yes.
Hypo, are you saying it's impossible? Hypo?
I'm not aware of.
As a cause of amenorrhea?
It's a cause of amenorrhea. It's not well documented. Billy?
Yeah.
All right. All right.
Yes.
I know of hyper, but
not hypo, yeah.
Okay.
But it's something,
Please clarify.
Homework.
Yeah.
It's a homework that we must go check up. I'm not aware of it. And then thank you Doc for a wonderful presentation.
It's a pleasure.
What is the pathophysiology of hypothalamic amenorrhea? And then how long should we wait after menarche for cycles to become regular? Can you just comment on this, Doc?
Which one? How long is?
What is the pathophysiology of hypothalamic amenorrhea? Hypothalamic is
It's got to do with hypothalamic dysfunction, where you're not releasing gonadotropin releasing hormone. And there also is, I just can't pin them in my head now, but congenital abnormalities that are also related with a poor functioning hypothalamus. Therefore, if you're not releasing gonadotropin releasing hormone, you're not going to release FSH and LH from your pituitary gland, therefore not stimulating your ovaries, not activating that endometrium, therefore not getting a period. So the problem is in the hypothalamus, which is high up in the brain.
Yes, that's very correct. But and these ones, if you give them gonadotropin and then agonists, they usually do well, and they respond well in terms of fertility. So
yes.
And then how long should we wait for menarche? After menarche, so this is an adolescent who started with menses to have regular menses.
When should we stop what?
When should they have regular or frequent menses before we intervene? After how long must we wait? So this is a patient, a young adolescent who is starting, who post-menarche.
Yes.
If they come, yes. When do we get worried?
So when I was reading through it, they were saying it can take up to a year for it to regulate on its own. But obviously, I think, I mean, as a mother or as a caregiver, if your child has a period this month, skips 2 months, most women in the 6th month, they are coming to say this person is having a period irregularly. And by then you can already investigate once the patient presents to you. And depending on the comfortability of the family in terms of hormonal therapy, if they are saying, no, it's fine, can we please wait and see if it regulates on its own, you can give them about a year. If it doesn't, then you assist that cycle to find its more regular cycle. So I think it's very much in discussion with the family, with the patient, and in terms of their comfortability in assisting their period. But what I found in literature was that if it can take up to a year, some cases even 2 years before a period becomes regular. So I think you need to discuss with the family and decide with them how would they like to proceed.
Yes, indeed. And I think if the patient and the family is worried and concerned about the abnormal uterine bleeding, then there is nothing wrong with starting them on COCs. However, as long as we avoid the contraceptive options such as the progesterone only, such as Depo-Provera, as they may have an effect on they may cause premature artificial closure, and that may have an effect on the adult height of the adolescent who is still growing. I think that's all we need to be worried about. But there's nothing wrong with putting them on COCs. They are actually safe.
Yes, true.
Then there is a question, patients with cycles. Okay, I think we have answered this one. There's one question here. Doctors, thank you for the presentation. How do you manage a patient who presents with a PV discharge, smelling, no itching, use pads, and 1 month post non-hormonal IDC? What is IDC? Is it IUCD? IDC. This is just to the question is not clear, but like I said, one of the things that we need really to look into is to take a good thorough history. And we are seeing especially patients that, especially looking if the patient has had a previous seizure. And if someone has had a seizure, one must screen that patient for a possible of a niche. And we are seeing it as a cause of this bloody, not really frank blood, but some old brown-like discharge, foul smelling. And it's actually one of the common presentations of patients with ethmosil. So we really need to take a good thorough history and examine and see so that we can make a diagnosis. I think this should be the last question. It was an amazing presentation. How often do you come across Mullerian syndrome? I think probably they want to say Mullerian agenesis. I think that is my opinion. I'm not aware of Mullerian syndrome. Probably is a Mullerian agenesis such as in the Mayer-Rokitansky-Kusterhauser syndrome. At our clinic, at the where I work, at least I have at least 3 patients that we have diagnosed with recently in the past 2 years with Mullerian agenesis. So I don't know how, maybe your experience or Billy, but it is so it's rare, but it is there.
Yeah.
But why, especially there was a comment on 18 years old with amenorrhea, primary amenorrhea, and if you have an 18 years old amenorrhea, it is always one of those differentials. You need to rule out this Mullerian agenesis. So any patient with primary amenorrhea, and as highlighted that menses should have occurred by 16, one should have a high index and they should be, it should be ruled out.
I agree. I think, I mean, the Mullerian agenesis, it's probably more common than what we see. It's just patients don't present. And then, I mean, in South Africa, we also have the added pleasure of having other treating modalities like traditional healers and chakra queens and all sorts of things. So before patients even present to us, they spend years in the alternate medicine space. And then by the time they come to see us, you can find that they are coming for mostly infertility. And then you will see that some of them will come because they haven't had a period. But before then, they would have presented themselves to all the other healing modalities already. So, and then some patients even just accept that this is not going to happen for me. And then they don't further follow up. Some patients will go to the clinic multiple times, not get the appropriate care or not get understanding explanation or level of care, and then just give up on the process and never present themselves. So it is a rare condition, but I think I've had one or two, and I've only been in practice for like 6 months. So much as it's a rare thing, I think depending where you are and the help-seeking behavior of that community, you can see quite a bit of it. So it does need a heightened level of suspicion and early investigation so that you're able to get to that diagnosis nicely.
All right, I think we can wrap up. There are no more questions. I think Billy, over to you.
Thanks, Dave. Thanks, Shadow. It was really an awesome evening. Thank you so much for all the, knowledge and skills that you've shared with all of us. We really appreciate it. Alice, any comments, brother? And maybe you can close for us.
Yes, I just wanted to appreciate the presentation. Dr. Nomshado, thank you very much. David, Billy, for always being available to host and to facilitate the discussions. But colleagues, without you, these sessions are not going to be feasible or even interesting. And I also want to really welcome a whole lot of our African brothers and sisters from many other countries. It's always good to see you joining us. I saw people from Kenya, people from Namibia, Lesotho, everywhere, Nigeria. So yeah, let's continue. But importantly, as we learn and we improve our practice, let's also, do our part to share with other colleagues so that we can improve women's health in this space. Just also to remind you to always visit our website, consider the membership option so that you can get access to some of the resources that we have here. And Botswana, yes, Refilwe, welcome. Oh, you're saying happy Independence Day for Botswana. Yeah. Musibi Ofalen, your closing remarks, and then we call it a night. Thank you.
Oh, I just want to say thank you so much for the opportunity. I can't believe I was so stressed out and so nervous. Kanti, I'm so awesome. So thank you so much for the opportunity, Dr. Billy, for taking me up, and to many more teachings, many more sharing of knowledge. And yeah, thank you so much, guys. Ngiyabonga kakhulu, and have an awesome night ahead.
Thank you. Oh, Obina says it's happy independence for Nigeria as well. Okay.
Oh, my people,
Happy independence for Africa. Colleagues, that's it. Let's call it a night till we meet again. Tomorrow, by the way, we have the HIV masterclass on resistance and the use of the Stanford database and case studies with Dr. Leon. Night, everyone. Bye.
Bye.